Alright, I've done enough videos on women's health for now. Let me be a man and let's talk about male urogenital anatomy and how things work down there. We'll also be going over a couple of urologic emergencies and when you should be presenting to a hospital because of some very real complications. Obviously, we're going to start with the penis because, well, it's the penis. It's a spongy organ with the machinery to serve both sexual and urologic functions. The penis mostly serves as a conduit for the male urethra, a long tube that connects to the bladder and where men urinate from. But if you take a closer look, you'll also see that it gets input from the testicles through the vas deferens and the seminal vesicle. This is how the testicles that produce sperm cells create semen and ejaculate it through the urethra, and also how you came to be here watching this video today. This gateway is controlled by the prostate, which among its myriad other male hormonal axis functions serves to clamp down on one end while allowing the other through, so that urine and seminal fluid aren't mixing when you're trying to do one or the other. The prostate is also an organ that can enlarge with age or prostate cancer, which leads to symptoms like urinary obstruction that can be common in older men. So urinating seems pretty straightforward, but how does that other part work? To understand that, we need to talk about the penile anatomy and the mechanism of action behind an erection. Look at the cross-section in the diagram. In the middle, you can see two big structures called the corpora cavernosa. These guys are big masses of spongy erectile tissue that span the entire length of the penis in a pair just above the urethra. During an erection, the corpora cavernosa is doing most of the heavy lifting here. When sexually aroused, the spongy tissue starts to fill up with blood from the arteries that travel all the way down the length of the penis. These swell up the corpora cavernosa with blood and push out against the venous system. Compressing the veins against the walls of the tunica albuginea traps all of that blood inside and maintains the rigidity of an erection. This is how the normally squishy penis ends up becoming firm like a boner. Looking at the diagram again, you'll notice that the corpora cavernosa are surrounded by a white ring called the tunica albuginea. This is a layer of fibrous connective tissue that holds everything in place and provides structural support. For lack of a better analogy, I consider it like a sausage. The meat is the corpora cavernosa, and the casing is the tunica albuginea holding everything together. For our first complication, let's talk about how a penis can break. A penile fracture happens when the penis is forcibly bent during an erection, which you can imagine usually happens during sexual activity, from an awkward insertion angle, bouncing on it at the wrong time, etc. Even though there's no bone to break, what is snapping here is the tunica albuginea. This leads to a rapid loss of blood from extravasation into the rest of the penile tissues, and more noticeably, accompanied by sudden onset severe pain and swelling. This is a urological emergency that requires prompt surgical repair. Otherwise, long-term complications are very possible, like erectile dysfunction, or scar tissue formation, or painful curvature like in Peyronie's disease. The urethra can also suffer injury in about 25% of cases of penile fracture, and that's a whole nother system that would also have to be addressed in order to prevent urinary complications as well. But let's move on. Let's say the urologist did a great job reconstructing the penis, and a few months later, you're able to maintain an erection again. On a chemical level, this rush of blood to the corpora cavernosa is triggered by parasympathetic stimulation, causing a release of nitric oxide as a signaling molecule. NO activates guanylate cyclase to convert guanosine triphosphate, GTP, into cyclic guanosine monophosphate, CGMP. CGMP then activates protein kinase G, which finally causes a bunch of intracellular calcium to flood out of the smooth muscle cell, causing it to hyperpolarize and relax. This relaxation is what vasodilates the arteries and increases blood flow to the penis. Then, once the fun is over, phosphodiesterase 5 comes in to break down CGMP into 5' CGMP and brings the above process to a halt. But what if you wanted to keep the fun going? Then you have medications like Viagra, sildenafil, and Cialis, tadalafil, which were developed as phosphodiesterase 5 inhibitors. These medicines prevent PDE5 from breaking down CGMP, which then prolongs the signaling cascade instead. Then, once the medicines wear off, the normal process can follow through. When it doesn't, that ends up becoming our second urologic emergency. Keeping all of that tissue engorged with blood and preventing venous return means that that blood is getting stagnant and depleted, causing cellular damage. A prolonged lack of fresh, oxygenated blood causes penile ischemia, cell death, tissue damage, and potentially necrosis. This is going to have to be addressed back in the emergency department and hospital, and involve oral vasoconstrictor meds to reduce blood flow to the penis, or sticking a needle in there and aspirating the the blood directly, or a levofed injection right into the corpora cavernosa to induce vasoconstriction, or even full surgery, like with a shunt cut into the glands through the corpora. Another drawback of the PDE5 inhibitors is the way that they interact with other vasodilating medicines, like nitroglycerin, which is commonly used in heart attacks. And unfortunately, the population of older men likely to receive nitroglycerin for anginal chest pain overlaps quite a bit with the population of older men relying on medications like Viagra. Nitroglycerin works by causing vasodilation as well, which reduces myocardial demand. So when given to a patient who has also taken a PDE5 inhibitor in the past 24 to 48 hours, they can combine and cause a dangerous system-wide drop in blood pressure. This reduces blood flow to major organs and can be fatal. This is a textbook example of why we ask patients to be honest with the things that they've taken before we administer a medication. A little honesty can prevent a huge catastrophe. A similar effect can be seen when mixing PDE5 inhibitors with another type of drug, a street drug, one that's also nitrate-based and works to cause smooth muscle relaxation. Let me know in the comments if you think you know what it is.